hearing somebody describe rejection sensitivity dysphoria for the first time is usually experienced as a tremendous relief. First of all, I'm not alone with this. I'm not the only person with this. This is something that is not my fault, other than I didn't pick my parents well.
Rejection Sensitivity Dysphoria, or RSD, is a term that hits home for so many people with ADHD, but it's not really acknowledged in the research world. How is RSD different from social anxiety or even trauma responses? And, more importantly, how can ADHDers and their loved ones navigate its impact on relationships and self-esteem? Today, Dr. William Dodson is back with us for part 2 of this conversation, sharing his insights into RSD and offering practical strategies that actually make a difference. That's coming up next on episode 257. I'm Emily Kircher-Morris, and this is the Neurodiversity Podcast.
What is neurodiversity?
You see the world differently.
Autism spectrum.
Gifted.
Complexities that are inherently inside.
ADHD.
Dysgraphia.
Tourette's.
All brains are different.
You are exactly what this world needs.
This is the
Neurodiversity
Podcast.
I remember working with a group of teachers a few months ago, and we were talking about self-advocacy for students. One of the teachers was telling a story, and she said that she instructed the student to come up to the customer service desk so she could help them out. I had to clarify and make sure I heard this correctly, and I did. When anyone in her class needs some help, there is a designated desk that she calls the customer service desk, which is such a fun and easy way to normalize and destigmatize the process of needing help in the classroom. It's these quick and easy practices that can help set up our neurodivergent learners for success, because they'll be needing the ability to self-advocate in lots of situations. Practicing this in a setting where there is no shame in asking for help is a wonderful example of neurodiversity-affirming practices. Neurodiversity-affirming practices in our schools are so vital for students, and there are a ton of teachers who are doing so much to help our neurodivergent learners, whether they're labeled with an official diagnosis or not. The Neurodiversity University Educator Hub is a community of like-minded educators who are passionate about supporting neurodivergent kids. We only open the doors to the Educator Hub a couple of times a year, and right now is one of those windows. If you'd like to build your knowledge of best practices in neurodiversity-affirming educational strategies, we'd love to have you join us. In the Educator Hub, you get access to webinars, roundtable discussions, office hours, and resources that you can share out to your colleagues to build neurodiversity-affirming practices in your school. The Hub is co-facilitated by my co-author of Neurodiversity Affirming Schools, Amanda Morin, and we are excited to have you join us. The doors are only open until February 7th, so head on over to neurodiversity.university and click on the tab for the Educator Hub to join us, or just find a link in the show notes. Part 2 of my conversation with Dr. Bill Dodson is up next.
previously on the Neurodiversity Podcast.
It's not just the accountability piece. I think kids build self-esteem from being accountable and successful when they do things independently. And I think sometimes when we swoop in to save them, we steal their self-esteem a little bit. Mm-hmm. And that, I think, is can become a slow development of learned helplessness. And I completely do not think the intention is negative from parents at all. It's not malintended. It's meant to be helpful. But going back to just like your physical muscles, you have to let your children exercise those executive functioning muscles, even if it doesn't always work out.
That's episode 222. Find it wherever you get your podcasts.
Can I ask you a little bit about social anxiety and the overlap with RSD? Because, again, it's I think it's just important to recognize that while a lot of these things might look similar, in reality, they are different. So how do you tease apart the social anxiety from the rejection sensitivity, and recognizing probably that they can play into each other as well?
Yeah. I mean, you can win the negative genetic lottery and have both. And in fact, most people with ADHD do. Everybody agrees that somewhere around 70% of people with ADHD will have another active major psychiatric diagnosis. So very often the question is not, is it one or the other, but is it both? 57% of people with ADHD will have two or more coexisting major psychiatric diagnoses. That, as a practitioner, is really where the work comes on. Diagnosis of ADHD is very straightforward. It's that you have to check the whole rest of the DSM for what else might be working there.
Yeah.
And address that as well. So what's the difference between social anxiety disorder and rejection sensitivity? It's one of the hardest ones to tease apart. Social anxiety disorder, again, usually starts in childhood. And it's an intense anticipatory fear that if I go out into public, I'm afraid that I'm going to say or do something that's going to humiliate myself in front of other people. And even if I'm absolutely perfect, everybody is still scrutinizing me, constantly waiting for me to mess up. Almost always, though, when a person is able to force themselves to go out into public, go into parties and groups, go to a classroom where they might get called on to speak, if they're ever able to actually go and do it, things will fine.
Yeah.
The anxiety is much, much less. For people with ADHD, it's sort of the opposite. They're fine, going along, bopping along with life, doing well. Bam. They perceive something as being critical, rejecting the personal failure or something like that. And then, man, instantaneously, they feel awful. Social anxiety is before the event. Rejection sensitivity is after the event.
Yeah.
Now, the confusion is that by far the best medications for social anxiety are ones that are rarely used anymore, the monoamine oxidase inhibitors. They're just great. And the thing is that monoamine oxidase inhibitors work very well for ADHD as well. So there's probably back in there somewhere a biochemical link between the two. And what it would be pure speculation.
Yeah.
But there does seem to be sort of scattered evidence that somewhere back there they connect.
Yeah, there's some commonality. Yeah, that's fascinating. I think that differentiation between the anticipatory anxiety versus the reactive dysregulation, it's kind of this push and pull. Like you can definitely see how they influence each other. Like somebody might then become more anxious about being in certain situations if they're fearful of the rejection or whatever that might be.
Yeah, because these responses come out of our experiences with other human beings.
Yeah.
Whether real, perceived, or imagined. What we perceive is true for us.
Right.
Sometimes a person's walking down the hall, somebody passes, doesn't say hello, and immediately their thoughts are just consumed with, oh, that person hates me, they ignored me.
Yeah.
Their minds first running on rejection scenarios to which they then respond.
Yeah.
For something that actually didn't happen.
Yeah.
But it still hurts just as badly.
Totally. I know we're kind of going down the list of all of these things, like if it's this, if it's that, but you mentioned earlier specifically like mood disorders, like depression, they're much more pervasive, they're longer lasting, they're not necessarily congruent with the environment or the situations that are occurring. And so depression, bipolar, like again, I feel like there's probably a lot of confusion though between those two. Is there anything that you would really add with those about how that manifests or how to view those either as a clinician or as a person who's experiencing them?
Well, this is where the clinician earns his fee.
Yeah.
Is teasing these things apart because overlap of symptoms is built into our diagnostic system. In the DSM-4, which is the one I actually know the numbers for, we now have the DSM-5 since 2013. There were 295 separately named conditions in the DSM, but there were only 167 symptoms. So there's tremendous overlap. So if you look at the diagnostic criteria for ADHD and for bipolar, they share 16 features in common.
Wow.
And on top of that, if you look at people with bipolar, somewhere around 25 to 40% of people with bipolar are going to have ADHD as well. It's the second most common comorbidity for people with bipolar, alcoholism being first. So we don't care as a clinician. I don't care how they're similar. I want to know how they are different so I can tell one from the other. And so again, I go back to the definition of what a mood disorder is. The moods have taken on a life of their own, separate from the events of the person's life and outside of their conscious will and control. And they're primarily the major aspect of depression is the inability to experience pleasure and gratification from those things which were previously pleasurable. And so that's what we see is that mood disorders tend to come and go. There are periods of relative symptomatic normalcy, if you will. Whereas a person's always ADHD. Mood disorders tend to have an onset in late adolescence. Moods start taking a life of their own. The average age is 17.7 years, so senior in high school. Whereas with ADHD, that may not have been tremendously impairing, but you can see all the aspects of ADHD going well back into childhood. It has to be rooted in childhood.
Yeah.
ADHD moods are normal moods. Triggered, match the nature of the trigger, complete onset in a twinkling of an eye. You go from normal to being in the mood that fast. And it's very short-lived, almost always.
Yeah. You mentioned earlier, you talked quite a bit about some of the lifestyle changes that people can make to kind of help with all of these different things. I want to talk a little bit also, though, about the relationships that ADHDers have. You mentioned the piece about the genetic component and being around people who also are ADHD in your immediate family unit.
And also reactive.
Perhaps that could lead to some shared understanding, some shared experiences, if people are aware of it. But in general, I work a lot with young clients. I have adult clients as well, but this definitely impacts those personal relationships and social interactions so intensely. What are the next steps? What do we do there?
For those members of our immediate family wrestling with the problems of rejection sensitivity, helping them understand what's going on with them is usually very well received.
Mm-hmm.
Hearing somebody describe rejection sensitivity dysphoria for the first time is usually experienced as a tremendous relief. First of all, I'm not alone with this. I'm not the only person with this. This is something that is not my fault, other than I didn't pick my parents well. This is something that's genetic, part of this difference in my neurology. And there's something I can do about it. But most of all, this is not something I have to hide from others or even myself. I don't need to be shamed by this.
Mm-hmm.
This is something I can confront and make better. And what's more, there are people there who do have a personal experience of this. They know what it's like. That's one of the reasons why researchers avoid any knowledge about this, is that it can't be researched in the traditional way because it's an internal perception that's not always there, that if it is there, it can't be measured. And you got to have measures and numbers to get published. And that people don't want to talk about because they're embarrassed by it.
Yeah.
It's very, very hard to do actual research. And here's the important part, that will get published. Because if it ain't going to be published, they don't even start it.
No.
I spent years trying to get my researcher friends to have the slightest interest in this and completely failed. So just, add a couple of questions at the end of the research you're doing now so you can see how prevalent this is. And the reason they gave was it'll never be published. It's unpublishable.
I'm curious to see, because this is such, I think, a topic that people have become really aware of. I feel like as the people who are doing the research kind of age into that, maybe there'll be more of that drive, maybe it'll be more of that grassroots, whereas like people are going, I've experienced this, I want to learn more about it. But
yeah, I should have lived so long.
The other thing I think about this too, I work a lot with educators, I work a lot with families, and there's just so much importance for psychoeducation for people who are experiencing this. Because if they don't have the name for it, they can't self-advocate, they can't explain it.
Right. Usually what I do is I refer people to the articles that I've written for the general population, almost all of which are on the Attitude website.
We'll link to some of those in the show notes for folks too.
People with rejection sensitivity have trouble describing the quality of the emotions themselves. So it's helpful if they get, well, here's this article, that explains type of thing. It also gives a certain validity to it that, here's this doctor who got this published.
Yeah.
It's real. I've always been equally interested in the patients that I don't see. People who have ADHD, who have rejection sensitivity and all that other stuff, who are going along and leading unimpaired lives. Good close relationships, good marriages, good family, good friends, good children, good job. They're really doing well in life. And they've never taken a pill in their lives. Those people know something that I want to know.
Yeah.
The one thing that I have found in every single case of people who are doing well is that when they were children growing up, they had somebody who was their advocate. The other word that's in the literature that I don't like is a cheerleader. But this can be anybody. Ideally, it would be a parent. But it could be a grandparent, a family friend, a coach, a next door neighbor, anybody. But anyway, they're able to give a 3-part message to the child on a consistent basis. First part is, I know you. If anybody could have overcome what you're dealing with through just hard work and intellect, it would have been you.
Mm-hmm.
This is not that the explanation everybody gives, well, you're not trying hard enough. No, people with ADHD are the hardest working people I've ever met. They've devoted their lives to getting on top of this.
Mm-hmm.
Second piece is, and what this tells me is that we're dealing with something that neither of us have identified yet. It's unknown to us. We see its outcome, but we don't know yet what's causing it. And the third part is, and I want you to know, I will stick with you until we figure this out and master it. Because the most traumatic thing for a kid is to be facing all of this alone, without support. And what advocates really do is that when things go wrong, just, they're in the toilet, that person keeps the memory of that child as a good, valid, hardworking, likable person, even when the person can't remember it.
Mm-hmm.
This is not your fault. You're not lazy, stupid, or crazy, and I'm not going to leave you alone with it. Those people do well.
Mm-hmm.
And all of that is free. You don't have to pay my rates to do that.
Yeah.
And it's life-saving.
Yeah.
And anybody can do it, especially teachers.
Yes. You mentioned life-saving. And I know that the research really does show with ADHD that one factor that can really contribute to suicidal behaviors or even non-suicidal self-injury, but is impulsiveness. But I assume that probably that is also related to the rejection sensitivity. Not that somebody's clinically depressed, but they have that feeling is so intense and so strong when they experience that rejection that they take action that is self-harming.
And there's a lot of research on this. It doesn't get down to, where does this come from?
Mm-hmm.
And again, it depends on how the question is asked, where it's anywhere from tripling the frequency of both attempts and succeeded suicides, all the way up to 13 times the risk of having a hospital record of having self-injury.
Mm.
So severe enough to end up in an emergency room or actually an admission. So it's a big deal.
Mm-hmm.
What we found is, universally again, all the studies of the use of medication have been tremendously effective in lowering suicidal ideations, suicide attempts, and completed suicides. It's the most potent thing you can do. The other thing, and this goes back to advocate again, is when you look at the people who actually have serious suicide attempts, it was sort of a fluke that they're still alive type of thing.
Mm-hmm. And
the people who actually go ahead and kill themselves, is that all of these people show, again, one thing in common, and that is they feel that their lives are worthless. They and their lives are not worth protecting. These are the people who just say, to hell with it, I'm going to get high and not feel this lousy. So a lot of these people end up drug abuse that then adds even more to their impulsivity.
Mm-hmm.
Again, somebody who feels like, I have a future. that is worth protecting is not a suicide candidate.
Right.
They're going to be doing all the things they can to make life better for themselves. And so that's the feature I look for, is what Sigmund Freud called the restoration of morale. A hopeless patient does not get better. Doesn't matter what their diagnosis is can they have realistic hope that they can do things that will give them control of their lives back?
Mm-hmm.
And the nice thing with ADHD, it's the most treatable condition in all of medicine.
Mm.
If docs know what they're doing, which is the big problem. The stubborn clog in the pipe of treatment, we got plenty of medications. We got lots of patients. What we don't have are clinicians that know how to treat ADHD. It is not taught at any level of medical education, I can guarantee you. 93% of adult psychiatry residencies do not mention ADHD in 4 years of training, not a word. So that most adult psychiatrists are functionally illiterate. And those are the people that most adults are going to go to for help. We think of pediatricians as being sort of the reservoir of understanding and knowledge about ADHD. But in the last updated guidelines from the American Academy of Pediatrics, half of all pediatricians said that they were not competent to recognize, diagnose, and treat ADHD, even though that's going to be 40% of what they're asked to do. They are not prepared by their training.
Wow.
So that's one of the biggest problems. ADHD doesn't have a textbook.
Yeah.
If somebody wanted to know, how do I diagnose it? How do I manage the medications and stuff like that? There is nothing out there. That's what we're working on right now, is to write that book and get it out. The biggest problem is the first one, and that is recognizing ADHD. Because ADHD in adults doesn't fit the diagnostic criteria. They're pretty well useless for anybody over the age of 16.
But it's all we've got.
Yeah, it's all we've got. And the thing is that the organization that says they're going to develop adult criteria, absurd, just announced at their meeting last week that for the 4th year in a row, they have been unable to come up with adult criteria. And there's a whole bunch of reasons that their audience is not interested. But these, again, they're paralyzed by people who are inflexible in their thinking.
It could make such a difference in people's lives if they had this.
Oh, absolutely. It's really hard to move forward. And so you really need to know about ADHD, but we can't really tell you what the criteria are in adults. Dead in the water before you begin.
Yeah. Wow.
Yeah.
Dr. Dodson, this has been such a great conversation. And I feel like I could keep talking to you, but if you're talking to a patient who comes into your office and they're dealing with rejection sensitivity dysphoria, they've just come to this realization that this is the thing that's impacting them so strongly, what is it that you would say to them? What is the message that you would just really want them to hear?
I think the most important thing I want them to know is what I want everybody with an ADHD nervous system to know, impairing RSD or not. I ask them a question. Look back over your entire life, dredge up all the memories you can. If you've been able to get engaged and stay engaged with literally any task you've ever tried, have you ever found anything you could not do? Think about that for a second. What virtually everybody with ADHD responds is, after thinking about it for a while and sort of hemming and hawing, I say, no, if I can actually get engaged and not be distracted, I find I can do anything. That question changes everything. If there are certain situations in which you can literally do anything, you do not have a disorder. You do not have a disorder. You are not defective. That's the biggest impediment we have in the research right now, is all the research looks at people with ADHD as if they were not neurodiverse, as if they were neurotypical, but damaged.
Yeah.
Which is a very unfriendly and insulting starting point. So it's important for people to know, I am not damaged. I see it in my life. There are episodes in which not only can I do anything, but my mood's great, my energy's great, I'm gregarious. Life is good when I can get in the zone. So it's important for people to start with the notion of, I have a neurodiverse nervous system. And the goal here is to learn that nervous system inside and out and manage it the best way I can. That's the goal. But I'm not defective. It's sort of the meme that's out there right now about, why is this important to get a diagnosis? It's good to know that you're a very good zebra rather than a defective horse.
Yeah.
It's accepting yourself as being a neurodiverse zebra.
Yeah.
Second question I ask is, how and where did you learn what you know about yourself, about life, about your work, about your relationship with people? How did you learn what you know? Most people are kind of shocked by that question because they never thought about it. So what most people say is, well, I had to teach myself. I would observe what other people were doing that worked and say, I'm going to figure out what they're doing and I'm going to do that. And so they're self-made people.
Mm-hmm.
Every one of them. Not that many of them learned from books. So the importance of this is that it proves to them that they're already doing what they need to do. They are survivors. They got this far on their own, and so they can keep doing it.
Mm-hmm.
Again, it talks to the hope that things can get better. It's not that you have to learn new techniques, it's just have to apply them in different areas. You're already doing everything it takes to master your nervous system. So those are two fundamental changes in how a person thinks about themselves.
It makes all the difference.
There's nothing either good nor bad, but thinking makes it so.
Dr. Bill Dodson, thank you so much for all of your insights and for your time today.
Pleasure. Maybe we can talk again sometime.
The disconnect between what you see on social media about rejection sensitivity dysphoria, what's in articles like the ones Dr. Dodson has written, and what's in the research is really strange. It leaves people like me who are trying to share what we're learning about neurodivergence without spreading misinformation, feeling a bit lost on how to move forward. There is some emergent research, though. One study I'm thinking of, which I actually forgot to ask Bill about during our conversation, showed that not only do ADHDers have a stronger reaction to perceived rejection, but they also show a weaker response to positive feedback. This was measured using EEG data while ADHDers were exposed to different stimuli. We'll drop the link in the show notes for anyone who wants to check it out. But what really stood out to me in our discussion was how crucial it is for ADHDers to have a solid understanding of themselves, so they can recognize what's going on when those intense emotions hit. It ties into the idea of surfing the wave in dialectical behavior therapy, recognizing that emotions come and go. But if you don't realize you're in the ocean to begin with, that wave is probably going to surprise you and maybe even knock you over. It's really about being aware of what might be coming your way. I'm Emily Kircher-Morris. I'll see you next time on the Neurodiversity Podcast.
Our gratitude to Dr. Bill Dodson. There are links in the show notes so you can check out his work. Lots of new faces coming into the Educator Hub during this open window time this week. It really is a great place to share ideas and learn new ways to make your school or classroom a better place for all students. If you want to hop on board with us, you have until Friday, February 7th at midnight Pacific. Click the link in the show notes and register by Tuesday, February 4th and save 10% on the lifetime of your membership. I'll put the coupon code in the show notes for that too. Our host is Emily Kircher-Morris. Corey Orick is our office manager and production assistant. I'm the executive producer, Dave Morris. For all of us, thank you for listening, and we'll see you next time. This is a service of the Neurodiversity Alliance.